start in a minute.
Okay.
Hello, everyone. Thank you for joining me today. I've got a very special topic for you that a lot of people suffer with, and they may not even know they suffer with. If you or a family member suffer from headaches, pain in the neck, or issues with teeth grinding, then it might be to do with your TMJ. Today, I've got Dr. Priya Mistry, the TMJ doc, and we're going to discuss everything to do with your temporomandibular joint. Dr. Mistry, thank you so much for joining me.
Thank you for having me.
Look, I really appreciate, us coming on to, talk about this subject, because I really think it's an area that people don't get a lot of information on. And you're someone that has been, publishing a lot of work on, how can people get help for facial pain. It's one of the more difficult issues. If someone has bad facial pain, they really suffer from it. So I think this is a topic that's going to become more and more prevalent. And, I just want to kind of dive through a lot of the basics. But before we do, tell us about how you got into this area of practicing dentistry and a little bit yourself.
Yes, definitely. So I'd always sort of been interested in TMJ work, but I didn't really know a whole lot about it. So as you know, in dental school, they kind of give us just like the tip of the iceberg, just a little bit of information, but it's not a whole lot. And so I had come across many patients in my 13 years of practicing general dentistry where I just felt like, they can barely open their mouths. They're in a lot of pain, and I didn't really know what to do for them. And so I kind of just got lucky, and I met my mentor because my mother-in-law, thank you, Mom, gave me a beautiful necklace that I wanted to change the clasp on. So I happened to walk into a jewelry store that was owned by my mentor's wife. So her and I are both chatty. We got to talking. She told me what her husband does, and he stopped practicing general dentistry about 30 years ago and focused only on TMJ work. And so he's largely self-taught. He has traveled the world and worked with renowned physical therapists, osteopaths, naturopaths, and he's kind of combined everything that he's learned, and of course his own background in dentistry, to create his own modality of treatment that works really well for our patients. And so I started shadowing him in 2018. And I just became fascinated with what he was doing. So I've been working with him ever since, and I've learned so much, and so much so that I almost feel like I went to a post-grad program, right? And that's sort of what I've been doing for the past 2 years. And it really inspired me to start my YouTube channel, which thank you for checking out. It was a way of putting information out there because there's so much unknown to this, even to us dental practitioners, that our patients are really suffering. And I feel like the more knowledge that's out there, the more we can help people. So that's kind of my journey. And I'm so fortunate to have met him.
There's a real bit of synchronicity there, wasn't there? Like the universe was telling you, this is what you should be doing, Dr. Mistry.
Yes, I believe there was. I mean, if I had never received that necklace, again, thanks, Mom, I never would have walked into that store. I never would have, it just sort of took off. So
amazing. Yeah. And you're really right. Like in dental practice, in dental training, there isn't a lot of depth in what we learn about the temporomandibular joint. And for temporomandibular dysfunction, which we'll talk about, it is very limited and it's very vague on what we do for it. You can kind of define it and tell patients about it, but what they do with it it's a very difficult problem.
Right.
Just to start off with, just to kind of familiarize what people are kind of experiencing, what are the most common presentations that you're seeing in terms of symptoms to do with problems with their TMJ joint?
Right. So a lot of people think they have TMJ or they've been diagnosed with TMJ with because they have clicking or popping noises in their joints. And yes, that is very much a part of it. But more what we're seeing is muscle dysfunction in the muscles that surround and support the jaw. So there's a group of muscles that do this. And when these muscles become dysfunctional or go into a chronic pain spasm cycle, it can lead to a variety of symptoms. And so we really try to differentiate for our patients TMJ, problems within the joint, versus TMD, problems that have to do with the muscles that surround and support the jaw. So if there's clicking, popping in the joint, crackling, or episodes of the jaw locking, that's usually linked to a problem within the joint. And also the muscles around there are pretty angry at that point too, but typically it's within the joint. TMD, which is temporomandibular disorder or dysfunction, it's often called the great imposter disease. And I think it's very aptly named because that can manifest in so many different ways. So temporomandibular disorder, again, it recognizes that those muscles that surround and support the jaw, once they become dysfunctional, usually due to chronic clenching, chronic bruxing or grinding, simply even the way the teeth fit together can sometimes drive all of this, or imbalances along the postural chain. And that's one thing that can be hard to grasp as a dentist at the beginning of all of this. And so all of those things can make the muscles dysfunctional, and then it can start to manifest in a variety of ways. So typically, number one, we see headaches, any type of headache. Headaches are the number one reason people walk through our office door, closely followed by ear-related concerns. So ear pain, stuffy ears, vertigo, hearing loss, even tinnitus, though tinnitus, I think the causes for that are multifactorial. Jaw pain, neck pain, tingling in the jaw, arms, hands, etc. So really it can manifest as a lot. And oftentimes our poor patients have been on such a journey before they get here. They've been to see ENTs, neurologists, they're put on strong medications, or they're in pain management clinics. And it's just really one of those things that's, it's not taught in medical school or dental school, right? TMJ, TMD, not that much. And so it's one of those things that when our patients come to see us, some of them are pretty desperate for answers. So we see a lot of more facial pain and headaches. And that can go along with the clicking and popping, but it's a lot of that pain that's driving people into our door.
When you describe the postural chain, I think so you're kind of implying the muscles that run down the neck and back, right?
Mm-hmm.
So can you explain, do you see many connections between neck and back pain and what you're seeing in the TMJ, and are your patients reporting that?
Yes. So we see a lot of lower back pain, a lot of neck pain. So these upper cervical vertebrae, there's so many muscles hanging off of them, and everything's connected, right? So it can feed up and really affect the jaw. So patients that have been in car accidents and have pretty severe whiplashes, they'll come in and they'll say, I had a car accident and a week later my jaw started clicking and popping and never did that. Or 2 days later my jaw locked and I can't open my mouth more than this and I'm in a ton of pain. Same thing with low back. Everything's connected. And so the postural chain, when I refer to that, I'm talking about the feet, the hips, the shoulders, the cervical vertebrae, the whole spine really. And then the mandible is just hanging out in a sling of muscle. So it's highly responsive to imbalances in the postural chain. So if one hip is higher than the other, all the muscles going up and down have to kind of compensate for that. And it does feed up and affect the jaw. So I had a patient that fell on her tailbone going down the stairs, and the next day her jaw started popping. It had never popped in her whole life. She's in her 40s. You know, so we see a lot of that.
So what you're saying is that the whole body it can potentially be affected by a problem with the jaw joint, or vice versa, which is quite remarkable. Yeah, quite remarkable when you think about it, right? Now, I'm going to encourage people to kind of ask questions on this because I think there's a lot of people suffering from these issues.
Yes.
But what about quite a persistent problem that I'm seeing people report are migraines. How would you see? Because I mean, how would you just quickly differentiate that between headaches, and are you seeing a link there between TMJ problems and these issues?
Yes. So I've had a lot of discussions with my mentor, and his name is Dr. Arthur L. Parker. He's amazing, about headaches, specifically migraines versus cluster headaches versus tension headaches and TMJ and how it all relates. And what he said to me time and time again, because I come back to him, I always poke him with a lot of questions, but he says all headaches, regardless of type, they are mediated through the fifth cranial nerve. They are all mediated through the trigeminal nerve. And if we can lower the threshold of excitation of that nerve, we can positively impact headaches, meaning lessen them. So yeah, a lot of my patients come in with migraines, they come in with cluster headaches, ice pick headaches, tension headaches, hemicrania continua. And so I would love to focus on migraines only, but we really see so much of it, so many different types of headaches, but really it's just about getting that trigeminal nerve calmed down. And we think the muscle dysfunction leads the muscles to become inflamed and edematous. And that inflammation essentially puts pressure on the trigeminal nerve. which trigeminal neuralgia is really just a close by blood vessel putting pressure on that, right? So I think there's a link there and overlap there as well.
So you're talking about an overall mechanism to calm the trigeminal nerve. We'll talk a little bit more about the bits and pieces of the TMJ and the surrounding muscles in a second, so that people can kind of get a picture. But what we're saying is that if you're to find a solution for this, you need to calm down the root cause, which is the overactivation of this cranial nerve. And if you look at a picture of the trigeminal nerve, it's one of the biggest nerves in the body, and it's probably the most important. I would definitely say it is, but from what you're saying in your experience is that nearly all headaches are associated with problems with this cranial nerve.
Yes.
And so, look, I'm just going to throw up a question because it ties in a little bit to what you mentioned about ears. You said people report ears issues. So, and it's also a problem that I'm seeing more in patients too. So would you, Paula asks, is slight vertigo a symptom of temporomandibular dysfunction?
Hi, Paula. I would say yes, it is. We see that quite often. And we are able to resolve that with the orthotics that we make that put the muscles in their relaxed position, and also some osteopathic cranial work to get the temporal bones kind of balanced again. So these temporal bones, which are part of the temporomandibular joint, they house the structures that control balance. And so if we can get those temporal bones kind of moving in sync with each other, whether we work with osteopaths or we're able to accomplish that ourselves, then we see that vertigo go down. So I would say yes.
Which is a really debilitating condition. So I think a lot of people would be really interested in this information. And just to clarify, because there are people asking who they see about this. So you're a dentist now. You obviously work with, and we'll talk a little bit more detail about this in later in the talk. But you obviously work with a team of people, but you're coming at this from lots of different angles, aren't you? Who would you recommend people see if they are suffering from TMJ problems, or they think they are?
Right. Whew, that's a hard question to answer. Starting with, I feel that starting with a TMJ dentist would be a good idea, to have a good range of motion exam done, a muscle palpation exam done, a joint exam done, but then also getting somebody who can look at the whole body involved. And so typically what we use are NUCCA chiropractors. A NUCCA chiropractor, NUCCA, N-U-C-C-A, stands for National Upper Cervical Chiropractic Association. So they're really well versed in working on the upper cervical vertebrae in a very gentle, non-forceful, cracking, jerky manner. But they also look at the entire body and where the compensations are happening, and working to release muscles that are working too hard or too strained. And it has a domino effect up that postural chain, essentially. So I think a team of practitioners is so important. But starting with, this area, getting to see a good TMJ dentist, and then also some body work. And hopefully if you can find a team that works together, that's really key.
We'll talk a little bit more about that and specific treatments a little bit down the track. But I just thought I'd get that out there, because there seems to be a lot of people interested into, where do I go for this? Because it is very difficult to find people that treat this in detail. And you're talking, we're going to get into these details. And so I think that's very helpful for people to know that specific chiropractors that deal with the cervical spine can actually, they're basically, this is their work, right?
Yes.
Now Bridget asks, now TMJ and choking and dysphagia and breathing, is it upper cervical? So are these type of issues with swallowing and choking feelings? Have you noticed this to be associated with these kind of problems?
Sometimes I have. The difficulty swallowing can be inflammation of muscles in this area. There's so many muscles that come off the hyoid bone, so we do some hyoid releases as well. So I think it's more the muscles in this area, but of course everything's connected. So I wouldn't put it past the upper cervicals being involved as well.
Yeah, like you certainly wouldn't rule it out.
No.
And definitely you'd be thinking about a full exam.
Mm-hmm.
Okay, so look, we seem to have covered, like what people are experiencing out there to some extent, but it definitely is extensive, isn't it? It's quite remarkable how this is a very this is a big problem out there. And
Yes.
so I'd like to get people, to understand a little bit more about the TMJ, because if we start to understand a little bit more, you can start to think about, how we can get issues with this. But there's also ways that we can kind of manage our day-to-day practice with the TMJ that we'll give some exercises for later. Can you describe what the TMJ is and some of the muscles that are associated and what they do? Because it's a remarkable joint, isn't it?
Yes, it's a very remarkable joint. So essentially, the TMJ is made up of two bony components. So there's the bony knob that our mandible ends on, and that's called the condyle. On top of that sits an articular disc. So I actually have an image here, Stephen, if you don't mind.
That'd be great, yeah.
Yeah, that'll kind of help me.
Yeah.
So this right here
Yep.
is the condyle.
Yep.
On top of that sits an articular disc, and on top of that is the temporal bone, which is a skull bone.
Yeah.
Yeah, you got it.
So the picture you're looking at is here.
Yep. Yeah, essentially. And so the disc, its job is to serve as a cushion or a shock absorber for the bony components of the joint. If that disc comes in or out of alignment, it'll click and pop and snick, and it can be uncomfortable, or it can click and pop for years without any pain. If it comes completely out of alignment, that is when the jaw locks. That is not a fun situation if you can't maneuver it into an unlocked position again. In front of the disc is a muscle called the lateral pterygoid muscle. I call this the troublemaker. I've heard it called the terrible, because when it goes into spasm, it can cause a ton of pain. It can refer pain into the ear, behind the eye. It can cause headaches. It's just not a happy muscle when it's like that. And it's about this size, the end of my pinky. It's not big. It's little, but it's fierce. And behind the disc, this way towards our ear, is tissue called retrodiscal tissue that has a ton of nerves in it. So when that little disc comes out of alignment, it goes too far forward. It pulls that nervy tissue forward, and that nervy tissue starts to serve as a shock absorber for the bony components of the joint. So it's very painful, because essentially that's being compressed every time we talk, chew, etc. So those are kind of the I guess the nitty-gritties of the joint itself, and that lateral pterygoid muscle can drive a lot of pain.
Can you just help people to locate the lateral pterygoid on themselves, either in the mouth or
Yeah. So essentially, if you open and close, you can feel the condyle moving. And so the disc is right on top of that condyle, and the lateral pterygoid is right in front of it. So a lot of people will come in and they say, I'm having pain right here. What is this? What's right here? And I'm like, that's the lateral pterygoid. It's they're always pointing right here.
I love the description that it's fierce too. That's such a good word for it.
It is fierce.
Yeah, right. Tiny little muscle, can be very pesky. Okay, so can you describe what the TMJ does? So the bones that it's moving, and the kinds of forces and the muscles that these bones use to move.
Yeah. So essentially, it's a sliding hinge joint. That's what it's called. So when we first go to open the condyle, that bony knob our mandible ends on, it first starts to rotate a little bit within the joint. Then when we open more, it starts to slide or translate down this an eminence that's on the temporal bone. And on full opening, it shouldn't really go beyond that eminence. If you do, you'll lock open. So some people are hyper flexible, and they have locked open because they go beyond that eminence. But essentially, on full opening, it should stop right at that eminence. And then when we go to close, the whole process sort of reverses itself. So that's kind of what's involved with the dynamics of the joints. It's also the most used joint in the body. I mean, speaking, chewing, clenching, grinding, that joint is just always working for many people because they're clenching all day long, or they're grinding all day long. Another thing that's unique about this joint is that for one joint to even be working or doing anything, the other one has to be doing something too. We don't have any other joints like that in our bodies. Like our wrists can work separately from one another, but these always have to work together. So what we see a lot is wherever the dysfunction is. So if this side has a lot of dysfunction within the joint, a lot of popping and clicking, a lot of people will have pain over here. And that's because this side's compensating. It knows something's wrong with this side. So it's kind of an interesting joint, I would say.
Absolutely. And for people that suspect or they have some symptoms, how would you say to do a quick test at home in terms of what would you say is normal opening range or sensation that they should be able to perform?
Yeah, 45 to 50 millimeters is normal opening. So that's maybe about 3.5 of my finger widths or
Yeah.
so.
Yeah.
Yeah, so 45 to 50, and then lateral 10 to 12 millimeters each way.
Yeah. So you should roughly get a little bit more, maybe 3 to 4 fingers, and then
Yeah,
moving, roughly, and it should be even too, right? Symmetrical.
it should be ideally,
Yeah.
yes.
Yeah.
And then
Exactly.
also when you open, it shouldn't really, your jaw shouldn't deviate over to one side, or it
Yes.
shouldn't have like an S pattern on opening. It should just open straight up and down.
Yeah, so let's describe some of these movements because this is really kind of where because we can kind of see that there should be nice, kind of clear, 45 to 50 mil opening. But so, what are some of the more subtle things that can start to go wrong, and that people can identify that their Team J isn't quite working the way it should be?
Yeah, the most frequent thing I probably hear is I suddenly some clicking or popping started and it wasn't there before, or it's getting more frequent than it ever was, or a lot of people wake up and their jaws are locked closed, and that never happened before. And I'm seeing that more ever since the pandemic started, because people, I believe, are clenching and grinding a lot more. So things
Mhm.
to look for, I would say, clicking, popping, headaches that are constantly coming on, jaw pain that wasn't there before. Those are kind of the main things that I would
Yeah,
look out for.
and and you mentioned teeth grinding, which is obviously a big factor for people that potentially do suffer from TMJ. How would you? I mean, so some people know their teeth grinding. They'll be told their teeth grinding.
Mhm.
What are some of the consequences do you think that flow on from grinding in terms of what happens to the TMJ?
Yeah. So it compresses the joint too much, essentially. The teeth aren't meant to be in contact with that much pressure. So what it
Mm,
does is it compresses all the components in the joint, and it can really start to squeeze on that disc that's in there. It's kind of like taking a watermelon seed and squeezing it between your fingers. Eventually it's going to pop out of alignment. It's going to go too far forward. So that's one thing. Once there's too much pressure in there as well, the bony components in the joint can start to break down. So that looks like loss of cartilage, roughened areas in the bone, which we see on our CT scans.
mhm.
So really, it can cause quite a lot of damage to the joint, and it can do it in a short period of time. So
I mean, what's happening here is that they're unconsciously in their sleep, they're activating these muscles controlled by this trigeminal nerve,
mhm.
and they're very strong. And you're describing the damage here that can be done. Not only, we kind of notice the dentition, right? We think, well, you're grinding your teeth, but really, probably the more significant damage is happening to the TMJ. Would you say that's true?
Yeah, I would say that there's significant damage happening to the TMJ, but also the muscles, right, that surround
Mm.
and support it. Those muscles are just getting angrier and angrier, and they can only take so much before symptoms will start to manifest.
Yeah. And do you think that the TMJ issue precludes the damage to the teeth? So obviously the late stage kind of signs of teeth grinding is a worn dentition. Do you think that the TMJ degeneration would preclude that?
I think so. Yeah, because it takes a long, long, long time for the teeth to wear. I mean, enamel is
Yeah.
harder than bone,
Yeah.
right? So you can do some damage to the disc, to the bony components of the joint before the teeth start to show it.
Yeah. Okay, so I'm just going to go to a few questions here just
Yeah,
to kind of see what people are feeling out. So Beverly Cox asks, is tinnitus a symptom? Have you seen that often?
I do. I see
Yeah.
tinnitus a lot. Um, Tinnitus is tricky because we believe that it's multifactorial in nature. So we believe, yes, of course, there's a connection with the TMJ,
Yeah.
but it could be other things as well. Um, so tinnitus is the one symptom we tell all our patients. We call it the joker in the deck, and it is the least responsive to treatment, or it responds the least predictably. So we say we can help your vertigo, we can help your stuffy ears, ear pain. Tinnitus is anybody's best guess. So I wish I could say it's fully because of TMJD, but there's got to be other causes, because we're really attacking it from different angles and we're still not getting a predictable response.
Which is good to know because I mean it's telling us that something else is going on, right? So we
Yes,
have to keep digging deeper. Yeah.
sure.
Okay. So look, someone walks into your office, can you describe a little bit about, and there's just a question here, about some of the investigations that you perform in order to understand what's happening with the TMJ? And so Tiffy asks, can TMJ or TMD be seen on an MRI?
An MRI can do a really good job of showing you exactly where the discs within the joint are. That's the only way that you can know where they are on opening and closing. So an MRI is useful for that. Yes.
And you mentioned the CBCTs. Is that kind of your standard?
Yes, we take CBCTs here.
Yep. Okay. So, and I imagine you recommend anyone with TMJ issues to get these kind of images.
Yeah, certainly. I mean, knowledge is power. So the more information that we have, the better.
Yeah, absolutely. What about scans with, do you send them for kind of spinal scans with the chiros or body workers?
Yeah. So if we send them to a upper cervical chiropractor, which I mentioned, NUCA, and then Atlas Orthogonal is another one. They work similarly. They take their own set of X-rays. So we send our CBCT with them, but I hear that they often don't look at it because they have their own way of imaging. So
this is the funny thing I find with chiropractors is that they're really kind of, they don't think about the mouth and jaw very much. I mean, obviously the NUCAs would more, but it's quite disconnected, isn't it? Have you found that in a way?
Yes, like I have. Yeah, they really don't. We had a patient whose father is a chiropractor, and she closed her jaw, and he brought her in and he said, I worked on her jaw once, and she said, stop it, Dad, you're making everything worse. And he said, so I'm bringing her here. And so yes, I see that a lot.
Actually, there's a question here that I think will be important. So trigeminal neuralgia is a particularly persistent issue associated with potentially TMJ problems. So Claudia asks, can you explain trigeminal neuralgia in terms of the TMJ?
Yeah, so I mean, I'll start off with a little anecdote and then I'll get into it. But we had a patient who was diagnosed with trigeminal neuralgia. She literally came to our office cradling her face in tears. She didn't even take her hand off her face her entire time. She was in so much pain. And she was on gabapentin, strong dose of it. And it was helping, but it wasn't really getting rid of the pain. So essentially we got her into treatment. We did our custom made mouthpieces, orthotics. We did myofascial release. We did tensing. We did a lot of different things with her. And she's now off her gabapentin. So she tapered off of it within 6 months. She doesn't take it at all anymore, and she's pain-free. So I'm not saying that anybody was wrong, but I'm saying I believe there's an overlap. There's an overlap between TMD and trigeminal neuralgia. And if we could work with neurologists to sort of figure out how we can work together to get our patients relief, I think that would be great. Anatomically, if you want to know more, I think it's just the muscles being so inflamed and edematous. They're putting they're putting pressure on the trigeminal nerve. That's the only thing I can think of, but there's definitely an overlap. Yeah.
And anyone with that kind of condition really needs to be thinking about good investigations into the TMJ just to rule it out, right? Even if it's just that. But in your experience, it seems to be something that obviously can help if you treat it effectively.
Yes, definitely.
Okay, so let's talk a little bit about some of the solutions in terms of, and so one of the more common questions I get is about teeth grinding. So if you have someone in the chair that's clenching a lot, how would you go about, you told us a little bit about your exam. Tell us a little bit about what you'd assess with their TMJ, but then what are your kind of treatment modalities in terms of getting them to stop grinding? And obviously there are your orthopedic guards, but what about some of the lifestyle factors as well?
Stress management, yoga, meditation, hydration, not too much caffeine. There's a lot. And then for daytime clenching, what I found that works well, but many people don't want to do it because it's annoying, is actually setting a little timer on your phone that goes off every 15 minutes. And every time it goes off, check where your teeth are. And I had a patient add an extra step to this. If she finds herself clenching, she has a little rubber band and she'll snap herself. So I said, well, I'm not going to tell you guys to hurt yourself, but she was able to train herself to stop clenching during the day. So I really believe it's possible to do it during the day. At night, it's really tough. I mean, we're asleep. I don't know the answer to that. I wish I had one. We do work with some TMJ physical therapists that have a biofeedback machine. So they hook you up and they show you which muscles are firing and which postures that you can assume to make it so that your muscles are in a more relaxed position, so they're not firing as much. And so sometimes we send some patients to them, but people that just clench so hard or grind so hard at night, I wish I had a better answer. I do think the grinding for many people can be related to sleep apnea or sleep disordered breathing.
Which was my next question. It's yeah. So the kind of prevalence and there's a big association here with the airway and of what the jaw's doing. How do you is sleep apnea in? Do you see patients with sleep apnea seeing these kind of symptoms? And what's your kind of approach in terms of, say you've got a patient with both snoring or obstructive sleep apnea, and potentially looking at how we address this, considering the TMJ.
Yeah. So patients come in and they're in so much pain that they just want to be out of pain first. And so that's kind of where I go with it. We do have a sleep apnea questionnaire that we have them fill out, and we talk to them about it if there's a lot of yeses checked off. And we do tell them, in the modern TMJ practice, we have to be very aware of the role of sleep apnea in TMJ disorders. And the CBCT that we have, it's great because it shows us the airway when you're standing up. So we can actually calculate out the volume of airflow, or we can just look at how constricted the airway is standing up. And it's always more constricted when we're laying back because our mandible drops backwards. And so some patients, when I say, your airway looks really constricted standing up, it probably is an issue when you're sleeping. What do you think about taking a sleep test? Some are all over it, and others are like, I'm not interested in that. I just want to get out of pain. So I kind of let the patients kind of dictate where they want to go with it, but I give them all the information. As dentists, we're not allowed to diagnose sleep apnea here. So, I just get them in touch with the right people if they want to go that route. And we kind of go from there. But I would say a lot of my patients have sleep disordered breathing. I would say a lot of them have tongue ties. A lot of them have low tongue posture. I mean, there's just so much that plays into all of this. And that's why I think a lot of dentists kind of shy away from wanting to treat it because, again, we're not trained in it. And there's so many factors.
It's so true that you kind of just pulled, we talked about, the postural chain muscles, kind of tying into to TMJ and headaches and all of these kind of symptoms that you can have with this problem. But then you've got this complex problem of the airway management during the night, the tone of the muscles of the tongue that support the airway, and also the posture as well. So you mentioned tongue tie. How do you see tongue posture as a connection to potential TMJ issues?
Yeah. So essentially, tongue posture is so important in orofacial development. So when the tongue is up against the roof of the mouth with a light suction, the maxilla can expand and it can grow to its full genetic potential, which ideally should be able to hold all of our teeth, including the wisdom teeth. And then what I find is if we develop that maxilla in children at a young age, 6 or 7 years old onwards, then the mandible kind of drops down and forward and follows, and it doesn't really need the same expansion oftentimes at that young of an age. What I found is that a lot of my patients have that low tongue posture, and I can see it on the CT scan. So that's what's kind of interesting is I know they have the low tongue posture. And so what low tongue posture does, a lot of these patients have that because of a tongue tie. So a tongue tie means that the band underneath our tongues is too restrictive. It doesn't allow the tongue to get up where it's supposed to. And so it kind of just sits on the floor of the mouth. Or people have adopted mouth breathing because they can't breathe through their noses. They have chronic allergies, they deviated septum, whatever it is, they've adopted mouth breathing. You can't breathe through your mouth unless your tongue is low. So that low tongue posture makes it so that the maxilla does not develop to its full potential. When these arches don't develop to their full potential, neither does the airway. So if we're not getting enough oxygen, our body senses that it goes into fight or flight when we're sleeping, and bruxing or clenching, especially bruxing though, is a response to that. And when we bring our jaw forward, it opens up our airway. It allows us to get more oxygen. So I see this so much. I see the low tongue posture. I see the tongue tie. I see the constricted airway. I see patients that have had premolars pulled and everything pulled back as part of their orthodontia. And again, when you pull everything back, that box, the upper arch and the lower arch that houses our tongue gets smaller. And where is our tongue going to go? It's going to go in our airway. It's just going to go back. So we see so much of that. And again, a lot of people are just happy to get out of pain. Others want, the whole thing. They want to know everything that caused it and what they can do about it to treat it. So we kind of cater it that way. But yeah, there's definitely a connection between the tongue tie, the sleep apnea, the smaller airways, the small arches, etc.
So you've kind of mentioned or alluded to that some of the solutions for the underdevelopment of the jaw, and including orthodontics, may associate with TMJ problems. Do you see a lot of patients that have TMJ issues after having orthodontic work?
Yes. Yes, and it's not even the orthodontic work where the bicuspids are extracted always. It's just orthodontia sometimes. And so we do see that. And again, not like blaming anybody, but the fact of the matter is that the two joints, the TMJs and the teeth coming together like cogs on a gear, that is a tripod effect. And so what happens when you cut off one leg of a tripod? The whole system goes out of balance. So moving teeth is a big deal and it affects the joints. So if they're moved in such a way that a joint is negatively affected, and again, it's not done on purpose, but it happens. And it happens most frequently in young women. We see young women post-ortho. The reason that young women have these TMJ problems more is hormones. But essentially, moving the teeth will definitely affect the TMJs. It may affect them to the point where it's causing a lot of pain or locking, or it may affect them to the point where our bodies can compensate and we never really have any symptoms, right? So I had the 4 bicuspid extraction retraction. I have a huge airway. I don't have any jaw pain. I came out of that really fortunate, right? So we see a lot. We see a big variety.
I see the same pattern with young women who have had ortho and the jaw issues. It's funny, isn't it, that there's do you think there's a connection there with so you've mentioned, so I've heard a lot of people starting to talk about hip dysplasia and hip issues in women. Do you think there's a connection here between the jaw and the hip? Can you talk a little bit about that?
Yes, definitely. So I think there's a connection in 2 ways because they're both part of the postural chain. So these muscle compensations will have a strong ascending effect or descending effect, depending on where there's more instability. So that's one way. And 2 is the hormones involved. So beta estradiol and relaxin are both linked to TMJ issues. So these joints have a lot of connective tissue in them. And connective tissue is highly under the influence of hormones. Beta estradiol and relaxin are linked to degeneration within the TMJ. And relaxin causes loose ligaments. It's women are meant to have kind of looser ligaments so that we can birth children. And so it's definitely related to the hips as well. It loosens things up. And so that those relaxin levels are fluctuating in young women quite a bit. And that's going to affect the hips and the joints. And then the postural change just sort of brings that all together too. So definitely it's more of a young women's thing. My mentor typically says 11-to-1 women to men.
Yeah, right. Really, 11-to-1.
11-to-1 is what he says. Well, so I've been working with him for about little over 2 years. I have seen hundreds of locked jaws where they can barely open, like hundreds in 2 years. Yep. 3 have been men.
Yeah.
3. So I see it too. I mean, it's largely a woman's problem.
It makes a lot of sense, that when we think hormonal effects on the collagenous material. So there's a question associated with pregnancy. Relaxin is especially associated with pregnancy, especially the later stages as the child grows and the body is ready to give birth. Do you see more TMJ issues with pregnancy? Is it associated with menstrual cycles? How does that relate in?
I see it some with pregnancy. I see a little bit more. Some people that already had TMJ, it gets worse during pregnancy. But I don't see a sudden onset with pregnancy. That I don't see often.
Yeah. There's a question here just touching on that. Natalie asked, Team J and Team D in pregnancy, pelvic instability in pregnancy, are they associated with this postpartum? What's your thoughts on that?
I would think so. It totally makes sense to me that it could feed up and affect the jaw. And I know a husband-wife pair of physical therapists where one takes care of the pelvic instability and one takes care of the TMJ problem. So they work really well together on that postural chain. But I would think that they are connected.
That is a great team, isn't it?
Yeah, right.
You mentioned some of the systemic contributors to potential TMJ pain. What other factors are you seeing? And besides, I mean, okay, so there's a lot of people on medications for headaches and TMD. Can you describe some of that and some of the other approaches to preventing facial pain?
Other approaches like, the medications?
Yes. Well, so there's medications, but so we talked about hormones. Are there, would you say, kind of foods and supplements or so that you
Sure.
use at all? Yep.
Yeah. So foods, we don't do too much like diet coaching, but we do talk about supplements in that sense. So for a lot of muscle pain, we do recommend magnesium. Magnesium, when it comes with calcium in a 2-to-1 calcium magnesium ratio, we found works really well. About 300 milligrams of magnesium a day usually does it for people. You can definitely take more, but magnesium is wonderful for treating dysfunctional muscles. So it can help calm those muscles down. And I'd say there's at least 2 patients here where we just could not get the lateral pterygoid, that troublemaker, to calm down. But then they started taking those supplements regularly and really committed to it. And that was sort of the trick. So it's like everything we did plus those supplements. So that's helpful. There are some supplements that contain like manganese or collagen, which will really help with the joint itself. It can help those ligamentous structures in the joint kind of tighten back up. I think the body has a huge capacity to heal itself. And sometimes it just needs a little nudge in the right direction, whether it be orthotics or these supplements that we recommend. So there are some that I say I would swear by because I've seen them work.
You mentioned locked jaw. Obviously, chewing is very difficult when you have this kind of dysfunction with the joint. Would you say that there's an association with chewing? So we're going to start to talk about, how people can kind of maintain their TMJ. Would you say that chewing is a way to kind of maintain the temporomandibular joint?
Chewing is fine. It's just excessive chewing. Like I would never recommend chewing gum. I never chew gum because I'm like too aware of the joint. And then if you are having pain, it's always good to baby the joint. So staying away from bagels, steak, beef jerky, things that are just too much. But just normal chewing is what I would recommend. Don't overdo it. Don't underdo it. Just have your meals.
So, I mean, yeah, I'm interested to know how you maintain your own TMJ, and there some home exercises that I've found that have been quite helpful for patients. But why don't we run through some exercises for the people watching as to how they can maintain the mobility and health of their TMJ?
Yeah. So one exercise that's a good one is these temporalis muscles right here. That are it's a big fan-shaped muscle on the side of the head here. Massaging that and really getting any tension or knots out of that muscle is a really great way to help decrease tension. Headaches just bring pain down overall. So essentially the way I would do that is there's like 3 moves to do that. One is running with the fibers. And so you can kind of take your middle knuckles or your fingertips. I'll do it with my fingertips here. And you can just kind of start right where that muscle starts. So it starts kind of right about here. Yeah. And then take your fingers and then just run back. So you can kind of see how I'm going all the way back and I'm putting pressure inwards. So just as much pressure as feels good. You don't need to overdo it, but doing this can help quite a bit with those tension headaches that can come on when we've been clenching all day or just stressed out at work and holding our jaw in a tense way. Another one to go along with that is now running perpendicular to those fibers. So then you're kind of just doing the opposite. You're just going this way and down. So pressure inwards and down. And then the third and last one that I think is the most effective actually just targets these anterior, the forward fibers of this muscle. So if you feel above your cheekbone and behind your orbital bone, there's a little depression right there. You can take 2 fingers and just put your fingers in that depression and just press in. And then you can even rub it in a circular motion, one way and then the other. And you can do this for 10, 15 seconds at a time. You can do this multiple times a day, but this really releases any kind of fibrotic areas that build up. If this muscle is kind of tough or fibrotic, it's always the anterior fibers. On my muscle palpation exam, that's kind of always where I find that muscle is not happy.
I hope everyone tried those exercises, because you can feel the palpable relaxation in the joint when you do it. And can you just describe that muscle, because it's a little bit hard to picture the temporalis muscle and what it does, because you really feel the kind of the tension that it holds.
Yeah, it holds a lot. So essentially, it's a big fan-shaped muscle, kind of like that size, if you can imagine. Yeah, it's kind of a big old muscle right there. So it originates in the temporal bone and the fascia, the connective tissue here, and it comes down and it attaches onto the coronoid process, which is part of the jawbone here. And what that muscle does is it elevates and retracts the jaw. So it brings the jaw up and back. And so that's kind of huge when we're clenching. Most of us bring our jaw up and back when we clench. And so it gets quite a workout, and it can get quite built up from that. So it's a key player in a lot of what's driving the dysfunction in TMJD.
Yeah. There's just a question here about, so there's another muscle that's quite prominent in the cheek. So Rachel asked, what about the cheek muscles? Can you get knots in your cheek and under jaw muscles?
Yes. So I was just going to go to the masseter next. So yes. Thank you, Rachel. So yes, you can. The masseter is this big muscle that runs right here. It is the biggest and most powerful muscle of mastication. It's huge. And so it starts under our cheekbone right here. So under the zygomatic bone, and it goes all the way down and inserts into the angle and the ramus of the mandible right here. So essentially, to release this one, I recommend 2 moves. The first is just taking your middle knuckles, which are these guys right here, and starting right where the muscle itself starts with pressure inwards. And this one, you can do a little bit more pressure than the temporalis. It can take it usually. So a little bit more pressure, and then just go all the way down slowly. It feels so good. So you're running with the fibers of this muscle in order to release it. So I do this sometimes when I'm doing therapy with my patients, and they love it. So that's one. And there's one more that I recommend with this masseter, and I'm going to grab a glove for this one.
Yeah.
So for this one, you're going to grab a glove. Sorry if you don't have one, Dr. So essentially, you're going to take these 2 fingers, your thumb and your pointer finger, and you're just going to go all the way back and grab the masseter as far back as you can. So just basically grab your cheek and then press inwards, pinch inwards, and slowly come forwards and out. And then same thing, go back in a little lower and slowly come forwards and out, pinching in, and same thing till you run along the whole length of the muscle. So now you're releasing it, running against the fibers of the muscle. So that way you're kind of attacking it from 2 different angles, essentially. So, and you can close once you get in. Yeah, it feels amazing.
Yeah, it's kind of that. Is it from the tense band of tissue at the back of the throat, right? Yeah.
Yes.
Yeah.
You got it.
On the back of the cheek. Yeah. Yes. I mean, you literally feel the tension release, right? And it shows you how much the joint and your posture is doing to, if those constant neural feedbacks are sending these messages, it's really weighing on you, isn't it?
Yeah, certainly. It's you can feel it release right away, and I'm not even one that's like that tense in that area, and I feel it. So did you want one more, or are we good?
Yeah, let's go one more. Yeah.
Okay, one more. So this one I like too. because it's the lateral pterygoid, so that troublemaker. So
Yeah.
not all of us can reach it on ourselves, and it's highly debatable in the dental community whether anyone can reach it on anyone. But I release this muscle every day, so obviously I believe that I can reach it. But essentially, again, so that muscle is right in front of the condyle. So if you open and close, you feel that bony condyle moving. So go right in front of it. That's where we're trying to go. So I pointed to the wrong side because I have a glove on this hand, but essentially right there. So what I do is if I want to reach this lateral pterygoid, I take the opposite hand with the glove on, and I take my pinky, and I basically go as far back and as far up as I can on that side. I go in with my mouth wide open, and then once I'm kind of far back there, I close down almost as much as I can. So don't bite, but almost bite. When you close a little, it opens up this area so you can reach in there more. So it opens it up on the inside so you can get more access, and just kind of reach up and as far back as you can go and as far up as you can go. And you'll kind of know when you get there because it usually hurts. And so what you want to do when you get there is apply pressure for 5 to 10 seconds. It should be a bit uncomfortable, but what this pressure does is it stimulates fresh blood flow, oxygen to that muscle. It stimulates lymphatic drainage, so toxins, lactic acids that have built up in that muscle get a chance to go. So we're trying to break that pain spasm cycle. So this, I'm going to look really cool here, but I open and then close, go all the way up. So I'm way back here on myself.
And you're feeling quite a pinch at the back of the cheek, right? Yeah, it's quite tight. Yeah.
Even on me, it's tight, and I don't really have TMJ issues. On my patients, it's like they'll tear up when I'm doing this on them, and I just say, if it's too much, tell me, just raise your hand. And so it can be incredibly painful.
Yeah. And so it's like a light pressure, isn't it, or like a reasonable pressure backwards, right? Yeah.
Yes.
Okay. I mean, so there's been a few questions on massage therapy, and so obviously people that have symptoms of TMJ issues, how do you see? I mean, you've mentioned a few obviously releases here that a dental practitioner can do, but how do you see massage therapy as a way to relieve general symptoms?
I think it's a great idea to help because if you can get the back and the neck muscles less tense, less fibrotic, and more relaxed, it's going to feed up and it's going to affect all of this. So some of my patients get massages regularly, others see their chiropractors regularly, and it just works really well. And what we notice is that the massages, the effects from it, or the effects from the chiropractic adjustments, they'll last longer because of our orthotics.
Yep.
So our orthotics are putting everything in their relaxed position. Then the chiropractors doing their work, everything just ends up lasting longer. So we work really well with all of these different practitioners here.
Yeah, absolutely. And a lot of dentists are doing that, but for some people out there that you may have to connect the dots between practitioners,
right?
If your practice doesn't have the connections.
Yeah.
So Karen has asked a question about Botox. So do you recommend Botox or Dysport injections in the masseter muscle for TMJ pain?
I literally just started editing my Botox and TMJD video that'll be on my YouTube channel next week. So stay tuned, but I will also answer right now. So we do not carry Botox at my office. That's not because I'm anti-Botox in any way, but a lot of my patients are because I'm in Portland and everybody has a very holistic mindset. Botox, when injected into the masseter, it can help in the short term. So it'll last for about 3 months, and it can help bring down pain levels quite a bit. What happens when you do it long term is this muscle starts to atrophy. And the consequences of that are it causes facial slimming, one, which women love and men do not because they want that chiseled jawline, right? And two, what it does is it can atrophy or weaken the masseter so much that it can actually potentiate sleep apnea by causing the mandible to drop even more further back when we're sleeping. So, Botox, I feel like it's a really good temporary Band-Aid, but after time, it can cause more harm than good, in my opinion, and it's very expensive. So I don't think it's a good long-term plan.
It makes a lot of sense. It's potentially for some people that have severe, but it's certainly not a long-term plan. And for these kind of issues, you really want to get to the cause, because you're just going to be running around in circles, right? If you don't find the what's actually causing the issues.
Right.
Okay, so we're coming to the end. You mentioned how you made orthotics in your office. Can you describe these a little bit, and how they help, and the purpose of them?
Certainly, yeah. So these orthotics or custom-made mouthpieces, what we do is we measure where the muscles are the most relaxed, and we use electromyography to do that. So that measures the nerve firing in muscles, essentially. So we measure where the muscles are the most relaxed and where the joints are aligned. We use our CBCT for that. And we build orthotics to that position. And once people start wearing those, good things tend to happen, because the muscles want to be in their happy place. They want to be in their relaxed position. And so once we make these orthotics, then we start seeing our patients once a week for our own kind of therapy that we do here. So it's myofascial release. We do kind of like a subtle head and neck massage where we release muscles, especially at the base of the neck, and this SCM, this big guy here. Then we follow that up with the myofascial release, and we do our own osteopathic manual jaw manipulation. So we actually will manipulate the jaw in such a way that encourages the disc in the joint to go back into alignment. So for those patients that are locked or have clicking and popping, we always do that jaw manipulation. What we find with this treatment that we do is that pain, headaches, neck pain, jaw pain, pain behind the eye, ear pain, stuffy ears, all those symptoms tend to go down drastically within a month. The clicking and popping we find takes 4 to 6 months to resolve. We start seeing the patients once a week, then we see them every 2 weeks, then every 3, until we can release them from treatment. So as they get better and better, we see them less frequently. But we do see that clicking and popping go away, and we're able to successfully treat locked jaws, which is difficult.
Really difficult. So it's amazing that I think it's great that you've kind of really focused on this area, because it's and I hope that this is going to become a wider a wider area of dentistry that we become more informed in, because it's such a problem. It's so debilitating. You can tell from the people that the patients that suffer from this affects your life in an insurmountable way. And so Dr. Mistry, I really have to thank you for the for all the work you've done and spending the time with us today. Now,
yes, thank you.
For those who are interested in more information, we've only been able to brush over quite superficially, but Dr. Mistry has a great YouTube channel. And can you tell us a little bit more about that and where people can find you?
Yeah. So if you go to YouTube and type in Priya Mistry or the TMJ doc, that's what I call myself, you can easily find my YouTube channel. I started it in August of last year as it was sort of a labor of love, because last year was super depressing. Like, let's be honest, right? So I thought, what can I do to kind of bring light and information into people's lives? And so I started that. And I'm really glad I did, because people have gotten some great information off of it. It's made people reach out to me and ask, who in my area do you know of anyone? So that kind of prompted me to research people in different areas that are practicing similarly to me. And so, yeah, it has a lot of information on there. If you have questions, I always welcome those, and I always answer everybody's questions. And so I think it's a really valuable tool. There's a wealth of information on there that I gained from my wonderful mentor and then I made into videos. So it's been my little labor of love. So I hope you do enjoy it if you watch it.
It's great. I highly recommend checking that out. And if they want to come and see you in person, you're based in Portland?
I am, yes. Portland, Oregon.
Dr. Mistry, thank you so much for joining us. It's been a pleasure. Yeah, I think there's going to be so much more conversation on this, and I really hope that these kind of discussions really pushes forward. Yeah.
Thank you.
No problem. I hope to talk soon. Yes. Thank you, everybody, for joining us today. Have a great day.
Bye.
We'll see you next time.
All right.